Length of a child we were talking about is double the birth length at the age of 4 years and is 3 times the birth length at the age of 13 years. So I was talking about how does the weight changes. So double the birth weight at 5 months, 3 times the birth weight at 1 year, 4 times the birth weight at 2 years, 5 times the birth weight at 3 years, 6 times the birth weight at 5 years, 7 times the birth weight at 7 years, and 10 times the birth weight at 10 years. This is how the weight was changing. How does the length change? As you can see, the length of a child becomes double the birth length at the age of 4 years and becomes 3 times the birth length at the age of 13 years. Now, there are certain formulas that I told you which are used to calculate the weight of the child if you know the age of the child. There is one formula to calculate the height of the child if you know the age of the child. Remember the 3 formulas I told you which are used to calculate the weight of the child? This is one formula that is used to calculate the height of the child. So what is the formula? The formula is age in years into 6 plus 77 centimeters. The only condition should be that the child should be between 2 to 12 years of age. So any child who is between 2 to 12 years of age, the height of the child can be given by this formula. Age in years into 6 plus 77 centimeters. So I'll give you an example. Suppose the child is 6 years of age and I ask you what is the height expected in a 6-year-old child. So use this formula. 6 into 6 is 36. 36 plus 77 centimeters. So comes out to be about 113 centimeters. So what is the height of a child expected at the age of 6 years? The height of a child expected at the age of 6 years is 113 centimeters. You just have to use the formula age of the child in years into 6 plus 77 centimeters. What was the formula that we were using for calculating the weight of the child? The formulas that we were using to calculate the weight of the child, I told you, 3 to 12 months. The formula was age in months plus 9 upon 2 kgs. For a child between 1 to 6 years, the formula was age in years into 2 plus 8 kgs. And for a child between 6 to 12 years, the formula was age in years into 7 minus 5 upon 2 kgs. Those were the formulas to calculate the weight of the child. This is the formula to calculate the height of the child. Age in years into 6 plus 77 centimeters. You can be given any age of the child. Only condition, the child should be between 2 to 12 years of age. So we did about weight, we did about length. Now we come to the head circumference of the child. So the third age dependent parameter is the head circumference of the child. Now please remember, the head circumference is always more than the chest circumference at birth by about 3 centimeters. So what is the difference between the head circumference and the chest circumference? Head circumference is more than the chest circumference at birth by about 3 centimeters. The head circumference and the chest circumference becomes equal at 9 to 12 months of age. So when does the head circumference becomes equal to the chest circumference? The head circumference becomes equal to the chest circumference by 9 to 12 months of age. Which is more? Head circumference is more than the chest circumference at birth. When does the head circumference becomes equal to the chest circumference? The head circumference becomes equal to the chest circumference between 9 to 12 months of age. Let us see how the head circumference of a child increases with age. So the head circumference of a child at birth is 35 centimeters. So what is the head circumference of a child at birth? The head circumference of a child at birth is 35 centimeters. Subsequently, as you can see here in the boxes, how does the head circumference increase? Now, total from birth till the age of 5 years, when the adult head circumference is achieved. So when is the adult head circumference achieved? The adult head circumference is achieved at the age of 5 years. Total from birth till 5 years, that is in the first year, in the second year, in the third year, in the fourth year, in the fifth year, total increase of 20 centimeters in head circumference occurs. So starting from the head circumference at birth, which is 35 centimeters, how much increase occurs till the adult head circumference is achieved? It is 20 centimeters. Let us see how does this 20 centimeter increase occurs. in the first year, 12 centimeter increase occurs. In the second year, 3 centimeters increase occurs. In the third year, 3 centimeters increase. In the fourth year, 1 centimeter. And in the fifth year, 1 centimeter. So please see this, how the head circumference is increasing. It is 12 centimeter increase which occurs in the first year. Out of 20 centimeters increase which occurs in 5 years in the head circumference, 12 centimeters you can see increase occurs in the first year only. Now this is very, very important. Head circumference is growing very, very fast in the first year of life. Out of 20 centimeter increase that occurs in 5 years, 12 centimeters increase occurs in the first year only. Then in the second year, there is an increase of 3 centimeters. In the third year, there is an increase of 3 centimeters. In the fourth year, there is an increase of just 1 centimeter throughout the year. So you can see how slow it has become. And in the fifth year, it is an increase of 1 centimeter. So I'm repeating again, out of 20 centimeters increase that occurs in 5 years, what was the head circumference at birth? 35 centimeters. Remember what was the length at birth? Length at birth was 50 centimeters. What is the head circumference at birth? The head circumference at birth is 35 centimeters. After 35 centimeters head circumference at birth, in 5 years, how much head circumference increase? You can see it increases by 20 centimeters. Now, how does this 20 centimeter increase occurs? 12 centimeter increase occurs in the first year, 3 centimeter in the second year, 3 centimeters in the third year, 1 centimeter in the fourth year, and 1 centimeter in the fifth year. And even if you see the first year, let us focus only on the first year. How much increase in head circumference occurred in the first year? It was 12 centimeter. So if you actually further see, in the first year, how does the head circumference increase? In the first 3 months, the head circumference increases 2 centimeters every month. So in the first 3 months of life, the head circumference increases 2 centimeters per month. Then between 3 to 6 months, how much head circumference increases? Now it increases just 1 centimeter every month. So in the first 3 months, it was increasing 2 centimeters per month. Then between 3 to 6 months, it is increasing 1 centimeter per month. And between 6 to 12 months, it is increasing 0.5 centimeters per month. So if you add up this, 2 centimeter per month for the first 3 months, so total 6 centimeter increase, 1 centimeter per month from 3 to 6 months, total 3 centimeter increase, and 0.5 centimeter per month between 6 to 12 months, another 3 centimeter increase. So if you add up these, this is how much increase occurs in the first year, 12 centimeters. So important thing that you need to remember, I am again focusing, let me just put it on so just see this, at birth, the head circumference was 35 centimeters. We are talking about head circumference. At 0 to 3 months, the increase then was 2 centimeters per month. Between 3 to 6 months, the increase was 1 centimeter per month. I'm just revising what I've already told you. And between 6 to 12 months, the increase was 0.5 centimeter per month. So if you add up this is 12 centimeter in the first year of life. So how much increase occurs in head circumference in the first year of life? It is 12 centimeters. So total in 1 year, increase of 12 centimeters. Then in the second year, increase is 3 centimeters. In the third year, increases 3 centimeters. In the fourth year, increases 1 centimeter. And in the fifth year, increases again 1 centimeter. This is how the head circumference is increasing. 35 centimeters at birth, 12 centimeter in the first year, and how you can divide this out of 12 centimeter in the first year, 2 centimeter per month in the first 3 months. 1 centimeter per month between 3 to 6 months. 0.5 centimeter per month between 6 to 12 months. Then in the second year, increase of 3 centimeters. In the third year, increase of 3 centimeters. After that, slows down even further, 1 centimeter in the fourth year, and 1 centimeter in the hip. So how much increase in 5 years? Total 20 centimeters starting from 35 centimeters at birth. I hope you have all understood this. So just one thing that you need to know. From the screen, just see, please see this. From the screen, just see that what is the time after birth when the head circumference is growing the fastest? What is the time after birth when the head circumference is growing the fastest? You will all agree it is the first year. You all agree. Because in the first year, increase was 12 centimeter. Now, even in the first year, what is the time when the head circumference is growing the fastest? You will all agree it is the first 3 months of life when the head circumference is growing at 2 centimeter per month. So, another FMG question. What is the time when the head circumference grows the fastest? First 3 months, 3 to 6 months, 6 to 12 months, after 12 months. So it is pretty clear the time when the head circumference grows the fastest is the first 3 months of life, when it is growing at a rate of 2 centimeter every month. So the earliest sign, please remember this, the earliest sign of hydrocephalus. A hydrocephalus is a very large head. Earliest sign of a hydrocephalus, and I am saying it is just a suggestive sign. It is not confirmatory. It is just suggestive of hydrocephalus if the head circumference grows more than 2 centimeters in the first month of life. This is very, very important thing that I am telling you. Suppose a child comes to me at birth, is brought to me at birth, and I have taken the head circumference of this child. It was 35 centimeters. We expect it to be 35 centimeters at birth. When he is brought to me now at 1 month of age, that means in the first month, at 1 month of age, I again take his head circumference, and now it comes out to be suppose 38 centimeters. It was 35 centimeters at birth, and at 1 month it comes out to be 38 centimeters. That means a growth of more than 2 centimeters in the first month. This is a suggestive sign of a hydrocephalus, a large head. What is exactly hydrocephalus? We'll discuss in detail when we'll do neurology. But right now, please remember, and I'm sure you all know what is hydrocephalus. It is a large head. And one of the earliest suggestive signs of a large head is head circumference growing faster than 2 centimeters in the first month. So suppose this is an FMG question I'm asking you. Earliest sign of hydrocephalus is choice A, head circumference growing more than 0.5 centimeter per month. B, head circumference growing more than 1 centimeter per month. C, head circumference growing more than 1.5 centimeter per month. And D, head circumference growing more than 2 centimeter per month. So what is the earliest sign? Answer is D. Earliest sign of hydrocephalus is when the head circumference grows more than 2 centimeters in the first month. How much it should grow? It should grow 2 centimeter per month. Just see this. It should grow 2 centimeter per month in the first 3 months. If it is growing more than 2 centimeters in 1 month, it is an early sign of hydrocephalus. I hope this is very clear to you. Okay, so we did about weight. So we did about weight, we did about length, we did about head circumference. We have talked about the 3 age-dependent parameters of growth assessment. Now let us come to two important questions. I've told you how the length of the child increases. I've told you how the weight of the child increases. I've told you how the head circumference of the child increases. Leave weight for some time. We focus on the length and we focus on the head circumference. Just let me remind you, the length normally at birth, if you remember, was 50 centimeters. And the length in the first year was 75 centimeters. Remember? So now if you are asked this question, increase in length in the first year, it was percentage of the birth length. BL is what percentage of the birth length. So what will be the answer? You are saying length at birth was 50 centimeters and the length at first year is 75 centimeters. So how much increase occurs in the first year? It is 25 centimeters. How much increase? 25 centimeters. So can you answer this question? Increase in length in the first year of life is what percentage of the length at birth? Answer will be 50%. Why? Because the length at birth is 50 centimeters and the increase in the first year in length is 25 centimeters. So the length of a child, the increase of length of the child in the first year is 50% of the length at birth. I hope it is pretty simple. Now answer the second question. Increase in head circumference. Now we have changed the length to head circumference. Increase in head circumference in the first year is what percentage of the head circumference at birth? So what was the head circumference at birth? If you remember, I told you it is 35 centimeters. And how much increase occurs in the first year? Last slide we did. How much increase in head circumference occurs in the first year? It was 12 centimeters. So how much increase in the first year? 12 centimeters. What is the head circumference at birth? 35 centimeters. So if you're asked this question, increase in head circumference in the first year is what percentage of the head circumference at birth? Answer is 33%. So please remember this. So please remember this. This is very important. Increase in length in the first year of life is 50% of the length at birth. BL is birth length. And increase in head circumference in the first year is 33% of the birth head circumference. So you understood? 50 centimeter length at birth, increase in the first year in the length is 25 centimeters. So increase in length in the first year is 50% of the length at birth. Similarly, what is the head circumference at birth? 35 centimeters. How much head circumference increase in the first year? 12 centimeters. So increase in head circumference in the first year is 33% of the head circumference at birth. So I hope it is now very, very clear to you. So with this, we finish up the 3 age-dependent parameters of growth assessment. We finished up weight, we finished up height, and we finished up head circumference. Now I come to age-independent parameters of growth assessment. If you remember, we did 2 age-independent parameters. First age-independent parameter, mid-arm circumference. Second age-independent parameter, skin fold thickness. I will not go into the detail of skin fold thickness. Whatever I had to tell you about skin fold thickness, I've already told you. I told you skin fold thickness is measured in the triceps area, triceps thickness, biceps area, biceps thickness, and the subscapular area, subscapular thickness. Which is the most commonly used? Triceps thickness. And I also told you the instrument that is used to measure the skin fold thickness is Herpendon's calipers. But for your exams, this much is enough. Let us focus on mid-arm circumference. A little more to be done about mid-arm circumference. Mid-arm circumference is taking the circumference of the mid portion of the arm. Another FMG question. What is the time when mid-arm circumference is usually used for growth assessment? Mid-arm circumference is used for growth assessment between 1 to 5 years of age. In some books, they have written 6 months to 5 years of age, but I think the best answer is 1 to 5 years of age. So this is the best time to measure mid-arm circumference as a marker of growth assessment. There are 2 ways to measure the mid-arm circumference. One is known as the Bangle test, please see on your screen, and one is known as the Shakeed's tape. The Shakeed's tape is there in front of you. What is a Bangle test? In a Bangle test, we take a bangle and the diameter of the bangle should be 4 centimeters. So what should be the diameter of the bangle? 4 centimeters. So take a bangle and try to pass it above the elbow. So what you are taking a bangle and you are trying to pass it above the elbow. If I can pass the bangle above the elbow, the child is a malnourished child. If I cannot pass this bangle above the elbow, the child is a normal child. I'll again repeat, take a bangle with a diameter of 4 centimeter and try to pass it above the elbow. If I can pass the bangle above the elbow, the child is a malnourished child. If I cannot pass this bangle above the elbow, the child is a normal child. So a bangle test is not telling me what is the exact mid-arm circumference of the child. It is just telling me whether the child is a normal child or a malnourished child. So is a bangle test a very accurate method for measuring the mid-arm circumference? No. It is just telling me whether the child is a normal child or a malnourished child. Which is a better method to measure the mid-arm circumference? The second method, which is the Shakir's tape. Now, a Shakir's tape is a tape which you can see in the screen. This tape is wrapped around the arm, the mid portion of the arm. And this is the portion. You can see the arrow portion. This is the portion through which the tape passes. This is the portion through which the tape passes. Now, if this portion, the arrow portion, comes to lie on the green color, that means the mid-arm circumference of the child is more than 13.5 centimeter. The child is a normal child. If this arrow portion comes to lie on the yellow color, that means the child's mid-arm circumference is between 12.5 to 13.5 centimeter. And if this arrow comes to lie on the red portion, that means the child's mid-arm circumference is less than 12.5. So at least better than a bangle test. A bangle test was just telling you a normal or a malnourished child. It was not telling you the exact mid-arm circumference. A Shakir's tape is telling you what is the exact mid-arm circumference. So if the mid-arm circumference is less than 12.5 centimeter, the child will be called as severely malnourished, severe malnutrition. If the child's mid-arm circumference is between 12.5 to 13.5 centimeter, the child will be called as mildly malnourished, mild malnutrition. And if the child's mid-arm circumference is more than 13.5 centimeter, irrespective of the age, between 1 to 5 years, which is the time when we use mid-arm circumference for growth assessment, between 1 to 5 years, any child who has a mid-arm circumference of more than 13.5 centimeters will be considered as a normal child. Any child who has a mid-arm circumference between 12.5 to 13.5 centimeter will be considered to be having mild malnutrition. And any child who has a mid-arm circumference of less than 12.5 centimeter will be considered to be having severe malnutrition. This is the classification of malnutrition, which is also known as Arnold's classification of malnutrition. Another FMG question, which is the only classification of malnutrition? Please pay attention. Which is the only classification of malnutrition which is based upon the mid-arm circumference? It is Arnold. Only classification of malnutrition which is based on mid-arm circumference. A, is it Gomes classification? B, is it WHO classification? C, is it Jellif's classification? And D, is it Arnold's classification? So what is the answer? The only classification which is based upon the mid-arm circumference of the child is the Arnold's classification of protein energy malnutrition. And what is Arnold's classification of protein energy malnutrition? It is there in front of you. Any child who has a mid-arm circumference of more than 13.5 centimeter will be considered as normal. Any child who has a mid-arm circumference between 12.5 to 13.5 centimeter will be considered to have mild malnutrition. And any child who has a mid-arm circumference of less than 12.5 centimeter will be considered as severe malnutrition. So only classification of malnutrition which is based on the mid-arm circumference of the child is Arnold's classification of malnutrition. right? So I hope this is very, very clear to you. Two methods to measure the mid-arm circumference: Bangle test, Shakid's tape. What is the diameter of the bangle used in a Bangle test? The diameter of bangle used in a Bangle test, 4 centimeters. A Shakid's tape is better or a Bangle test is better? I told you Shakid's tape is much better because it will tell you exact mid-arm circumference of the child. So just wrap this tape around the arm. If the arrow comes to lie on the red color, that means the mid-arm circumference is less than 12.5 centimeters. If the arrow comes to lie on the yellow color, that means the mid-arm circumference is between 12.5 to 13.5 centimeters. And if the arrow comes to lie on the green color, so arrow on the red color, less than 12.5. Arrow on the yellow color, between 12.5 to 13.5. Arrow on the green color, more than 13.5 centimeters. So any child who has a mid-arm circumference of less than 12.5 centimeters will be considered to be having severe malnutrition. Any child who has a mid-arm circumference which is between 12.5 to 13.5 will be considered to be having mild malnutrition. Any child who has a mid-arm circumference of more than 13.5 will be considered as having severe malnutrition. Now there is just one thing that I would like to tell you here. Please just pay attention, just one important thing that I would like to tell you. Now till now this was what was taught to us, that any child who has a mid-arm circumference of more than 13.5 centimeter was normal. Any child who had a mid-arm circumference between 12.5 to 13.5 centimeter was known to have mild malnutrition, and less than 12.5 centimeters was known to have severe malnutrition. However, there is now a certain change, and there are some new Shakid's tape available in which severe malnutrition is defined as less than 11.5 centimeters. So originally, severe malnutrition was defined as less than 12.5 centimeters. But now if someone asks you, what is the definition of severe malnutrition? Severe malnutrition now is defined as less than 11.5. So more than 13.5 remains normal. So it is now 11.5 to 13.5, which becomes mild malnutrition, and less than 11.5 centimeter becomes severe malnutrition. So there is a change. If someone asks you, what is the current definition of severe malnutrition? The current definition of severe malnutrition is mid-arm circumference less than 11.5 centimeters. Now please remember, malnutrition can either be mild to moderate, or malnutrition can be severe. Now it is the severe malnutrition which has been defined by the World Health Organization now by a new term. And what is that new term? You should know. That new term is severe acute malnutrition. So we just look at that term, severe acute malnutrition, and talk about what is the definition of severe acute malnutrition. So malnutrition can be mild to moderate, it can be severe. Let us talk about severe malnutrition. Severe acute malnutrition is a term which has been given by the World Health Organization and is defined as bilateral presence of pitting pedal edema. The edema should be nutritional in origin. The only cause of this edema should be nutritional. Weight for height less than 3 Z scores. When I say 3 Z scores, that also means 3 standard deviation. And mid-arm circumference less than 11.5 centimeters. Any of these 3 criteria may be present. You do not need to have all the 3 criteria. Any of these 3 criteria can be present. The child may have bilateral edema in the legs. The child may have weight for height which is less than 3 standard deviation of less than 3 Z scores. Or the child can have a mid-arm circumference less than 11.5 centimeters. The child should be between 6 to 59 months of age. So any child who is between 6 to 59 months of age and who has any one of these 3 criteria, bilateral pitting edema, weight for height less than 3 standard deviation of 3 Z scores, or mid-arm circumference less than 11.5 centimeters, the child will be considered to have a severe acute malnutrition. Very, very important new topic which is asked many times in the exams. What is the definition of severe acute malnutrition? Child between 6 to 59 months of age with any of these three criteria: bilateral pitting edema in the legs, weight for height which is less than 3 Z scores or less than 3 standard deviation, and mid-arm circumference less than 11.5 centimeter. I have seen PG entrance students confusing. They feel all the three criteria should be present. No, any one of these three criteria. In a child between 6 to 59 months of age, you should think of severe acute malnutrition. Majority of cases, management of severe acute malnutrition is done on outpatient basis. That means in the OPDs. Majority of cases. However, what are the criteria for admission? This again is an important topic for your exam. What are the criteria of admitting a child of severe acute malnutrition? So the criteria should be either the child has a very severe edema, and when I say very severe edema, it is 3+ edema, very severe edema, or the child has loss of appetite, or the child has complication of malnutrition, or the child has danger signs, which are defined by the integrated management of newborns and childhood organization. So there is an Imnci protocol, and you do not need to go into the details of that protocol, but that protocol is basically a protocol for the management of diseases in neonates and in children, in the community basis and in the hospital basis. So what is that protocol called? It is known as the Imnci protocol. Now please remember, there are certain danger signs there. For example, I won't go into the details, but for example, a danger sign is the child has lack of feeding. So he is not feeding at all. Or the child is having very severe dehydration. Or the child is not taking any food. The child is not taking any fluids. So these danger signs, the child is severe hypothermia. The child is having hyperthermia, high temperature. Any of these danger signs present in a child of severe acute malnutrition, or a child having complications of malnutrition, or a child having loss of appetite, or a child having severe edema. These are the 4 criteria which require that the child should be admitted. Is it clear? So severe acute malnutrition can be managed in the OPD, can be managed in the hospitals after admission. So what is the criteria for hospitalization? Severe edema. Second, loss of appetite. Third, complications of malnutrition. And fourth are the danger signs. Danger signs such as lack of thirst or unable to take fluids, unable to take food, hypothermia, hyperthermia, signs of infections, septicemia. So these are the danger signs. There can be any danger sign present. There can be a complication of malnutrition present. There can be loss of appetite, and there can be severe edema. Any of these 4 criteria if present, this child requires admission. So just quickly repeating, severe acute malnutrition is usually in a child between 6 to 59 months of age who has one out of these 3 criteria. So what are the criteria for the definition of severe acute malnutrition? Bilateral pitting edema, which is nutritional in origin, weight for height less than 3 Z scores, and a mid-arm circumference which is less than 11.5 centimeter. Any of these 3 criteria present, the child will be called as having severe acute malnutrition. Can it be managed in the OPD basis? Yes. Can it be managed in the hospitals? Yes. But criteria for hospitalization are these 4. Severe edema present, or there is loss of appetite, or there is complications of malnutrition, or there are danger signs. Any of the danger signs that I told you, hypothermia, hyperthermia, signs of infection, not able to take fluids, not able to take food, these are danger signs. Any of them present, that also is a criteria for admission. In fact, severe acute malnutrition is a very important term, and this time, if I recollect, 3-4 days back in the AIMS exam that was conducted, there was a question that was asked on severe acute malnutrition. And what was the question? The question was this. I'm not exactly knowing the question, but it was something like this. Which of these is not a criteria of severe acute malnutrition. And what were the choices that were given? The choices that were given was edema. The second choice was weight for height. The third choice was mid-arm circumference. And the fourth choice was weight for age. So now it is pretty simple, which is the criteria which is not used to define severe acute malnutrition. It is weight for age. The criteria are edema, which is present in the legs, then weight for height, which is less than 3 Z-score, so which is less than 3 standard deviation, then mid-arm circumference less than 11.5 centimeters. So any of these 3 criteria present in a child who is between 6 to 59 months of age, we call this as a child having severe acute malnutrition. So I hope it is pretty clear and there is no confusion at all. And what are the ways by which you manage? Either you manage severe acute malnutrition in the OPDs or you hospitalize these children. What are the criteria for hospitalization? The criteria for hospitalization I've been telling again and again. First criteria of hospitalization, which is very important, is severe edema, 3+. Second criteria, loss of appetite. There should be loss of appetite in the child. Third, complications of malnutrition. And fourth, any of the danger signs. Hypothermia, hyperthermia, loss of thirst. So the child is not able to drink fluids. The child is not able to drink food, eat food. And the child is actually having signs and symptoms of infection, septicemias. These are the danger signs. So even if these danger signs present, admit the child, hospitalize the child. Okay. So I hope till here everything is very clear to you and there are no significant queries that are there in your mind. Even if you have the queries at the end of the class, you can ask me those queries. But right now, let us move ahead. The next topic that I will do now is short stature in children. Now, before I come to short stature in children, let me tell you what is short stature. Short stature, basically speaking, is a height of a child which is less than 2 standard deviation from the expected. So any child who has a height which is less than 2 standard deviation from the expected, we call this child as a child having short stature. Short stature simply means a child with a short height. There are 2 types of short statures. The first type of short stature is known as a physiological short stature. That is how you define it in GAI, which is also known as a normal variant short stature. And the second type of short stature is known as a pathological short stature. A normal variant short stature is a short stature in which the child's growth velocity is normal. So a child whose growth velocity is normal will be called as a child having a physiological or a normal variant short stature, while a child whose growth velocity is reduced will be a child who will be called as a child having a pathological short stature. So one of the best ways of defining short stature is to see the growth velocity. Now you may ask, so what is growth velocity? Growth velocity simply means how much height a child is increasing every year. Every year, how much height the child is increasing. For example, if you remember, what was the length at birth? 50 centimeters. Just pay attention to what I am saying. What was the length at birth? 50 centimeters. What is the length in a 1-year-old child? 75 centimeters. So how much length increased in the first year? 25 centimeter length increase in the first year. So what is the growth velocity in the first year? It is 25 centimeters. So growth velocity is the height increase in 1 year, approximately 1 year. So if the child is increasing the same height as a normal child, still the child is short, the child will be called as a child with a physiological short stature. On the other hand, if the child's growth velocity, how much height the child is increasing every year, that is less than normal, this child will be called as a child having a pathological short stature. Now, physiological short statures again can be divided up into two categories. The first type of short stature is a familial short stature. Familial short stature is sometimes also referred to as a genetic short stature. While the other type of short stature which comes under physiological short stature is a constitutional delay. So there are two types of physiological short statures. One is known as a familial short stature, the other is known as a constitutional delay. Mind you, in both these cases, the child is having a normal growth velocity. So then a question that students ask me is, if the child is increasing height normally like any other normal child, why is the child short? So in a familial short stature, familial, the child is short because the parents were short. So because the parents were short, so the child started with a short length at birth. Now after that, even though the child grew normally every year, the child will never be able to cover up for his height. So the final stature will always be short. On the other hand, in a constitutional delay, what is a constitutional delay? See here, just please pay attention here. This is how a normal child grows. This is the growth curve of a normal child. So just pay attention here. There are certain children who at least initially they grow normally. Just see this curve. Initially they grow normally. This is the short stature child. So initially, as you can see, initially the child was growing normally. Then suddenly, somewhere around 1 to 3 years of age, the child starts to show a slight decrease in the growth velocity. But later on, around the adolescent time, the puberty time, the child grows faster than that of other children. So ultimate stature that they achieve is almost normal that of other children. So a normal stature is achieved. So at least initially the child may be short, but later on the final height will be normal. You understand? That is why we do not call it as a constitutional short stature. We call it as a constitutional delay. These children will attain a final height which is normal. They will attain a final height which is normal. But at least initially they are short. For example, if the child comes to me at the age of say this time, 5 years. So a normal child will be lying here while this child will be lying here. So this is short stature at this time. But the same child will go faster in the pubertal time and will ultimately achieve a height which is normal. So you can see here, this is final height which is normal. How do you differentiate it from a familial short stature? Remember, in a familial short stature, the final height was short because the parent's height was short. But in the case of a constitutional delay, the final height is normal. So there should be no confusion. While in a familial short stature, the final height was short. In a constitutional delay, the final height is usually normal. That is why we do not call it a constitutional short stature, because the final height is normal. It's only a delay in achieving that normal growth. Hence, the appropriate term is a constitutional delay. So initially growing slow, later on growing fast. So final growth velocity, normal. So short stature, physiological or a normal variant, and pathological. Physiological, again of two types. One is familial and one is a constitutional delay. What is the basic difference between them? The basic difference between them, first basic difference between them is the final height. So the final height is usually always short in a case of a familial short stature, while the final height is usually normal in the case of a constitutional delay. So final height normal in constitutional delay, final height is short. Another important difference between them is puberty. So puberty usually comes on time in a case of a familial short stature, while puberties are usually delayed in the case of a constitutional delay. So just remember the term delay, constitutional delay. So a delay in achieving a normal height, also a delay in the timing of puberty. That is why the name delay. So which is the type of a normal variant short stature, physiological short stature, in which the puberty comes on time? Answer, familial short stature. Which is the type of a normal variant short stature or a physiological short stature in which puberties are delayed? Answer, constitutional delay. Which is the type of a normal variant of physiological short stature in which the final height is always short? Familial short stature. And which is the type of a normal variant of physiological short stature in which the final height is usually normal? Constitutional delay. So you are seeing the differences. Both of them, familial short stature and constitutional delay, both of them are physiological short statures, but there are certain differences between them. How do you define a pathological short stature? How do you classify a pathological short stature? Physiological short stature, I told you, growth velocity is usually always normal. But in a pathological short stature, the growth velocity is usually reduced. A pathological short stature so let me show it here. So let me show it here. So pathological short stature So we have talked about physiological short stature. Now let us focus on pathological short stature. Pathological short statures are of two types. One is disproportionate short statures and one is proportionate short statures. So how do you classify pathological short statures? Physiological, we have already seen how we classify. How do you classify a pathological short stature? I'll again show you. This was physiological. Physiological we converted into familial and constitutional delay. Now how do you define a pathological short stature? Pathological short stature, disproportionate and proportionate. Disproportionate, the upper segment to the lower segment ratio is abnormal for age. What is US? Upper segment. Upper segment is from the head to the symphysis pubis. So this is our upper segment, from head to symphysis pubis. What is the lower segment? From the symphysis pubis to the toes is the lower segment of the body. I'll again repeat. What is upper segment? From the head to the symphysis pubis. What is the lower segment? Symphysis pubis to the toes. Now this upper segment to the lower segment ratio, the body's total proportion, it changes with time. How does it change? That I'll just tell you. But before I tell you that, just remember, upper segment to lower segment ratio changes with age. If the upper, that means this is a child who has a disproportionate short stature. But if the upper segment to the lower segment ratio matches with that age, so upper segment to the lower segment ratio is normal for age. We call that as a proportionate short stature. Now, please just pay attention again, something again which I want to tell you. A little confusing, but if you just pay attention to what I am saying, I don't think it will be too much of confusion. Disproportionate short statures, the upper segment to lower segment ratio is not matching for that age. Disproportionate short statures can again be of two types. The upper segment to the lower segment is more for age. The second upper segment to lower segment is less for age. Just pay attention. I will tell you a little later what is the upper segment to lower segment ratio for each age. Just try to understand. If the upper segment to the lower segment ratio for a particular age that we know is this is the normal for a particular age. I'll give you an example. Just pay attention. If the upper segment to the lower segment ratio we know for a 3-year-old child is 1.3. So what is upper segment to lower segment ratio for a 3-year-old child? It is 1.3. Just pay attention here. If the upper segment to the lower segment ratio for a 3-year-old child is 1.3, and this short stature child also has a ratio which is 1.3. He's short, but when I take his upper segment and the lower segment ratio, it is 1.3. He has a proportionate short stature. If this ratio is not 1.3, it is either more than 1.3 or less than 1.3, it is known as a disproportionate short stature. You understand? If it is 1.3 for a 3-year-old child, it is proportionate. If it is less than or more than 1.3, it's not matching, then it is disproportionate. Now, disproportionate again can be of two types, as you now understand. This ratio is not matching. 3-year-old child, it should be 1.3. It is more than 1.3. So, upper segment to lower segment ratio, more for that age. Upper segment to lower segment ratio, less for that age. So, it is less than 1.3, it is less for that age. This type of disproportion is known as infantile disproportion. And this type of disproportion is known as advanced disproportion. Just two names that have been given. So if the upper segment to lower segment ratio is more than expected, infantile disproportion. If it is less than expected, advanced disproportion. And if it is according to expected, it is not disproportionate, it is proportionate short stature. I hope it is very, very clear to you, because you people are not there in front of me directly, so I cannot really know whether you are understanding or not. But just try to understand, there is no problem at all. See, whenever a short stature child comes to us, just put your pens down and just hear what I am saying. Whenever a short stature child comes to you, you have to first find out whether every year his height was growing normally according to age or not. If his height was growing normally, that means growth velocity was normal. He will be called as a child having a physiological short stature. If his growth velocity is not normal, he will be called as a pathological short stature. Once the child has a physiological short stature, that means his growth velocity is normal, I will see whether his parents were short or not. If his parents were short, he will be called as a child having a familial short stature. And another type of physiological short stature is a constitutional delay. Now, what are the differences between a familial short stature and constitutional delay? A familial short stature, the final height is usually always short because the parent's height was short. But in a constitutional delay, the final height is usually normal. Second difference between them, in a familial short stature, puberties always come on time. This is very, very important for your FMG exams. Which type of normal variant short stature, puberty always comes on time? It is a familial short stature. Which type of a normal variant short stature or a physiological short stature, puberties are delayed? It is a constitutional delay. Clear? Now, suppose the growth velocity was reduced. This is a pathological short stature. How do we divide pathological short statures? Pathological short statures are divided into disproportionate or proportionate. How do we know this is disproportionate? Proportionate based upon calculation of the upper segment to the lower segment ratio. So calculate the upper segment, vertex to symphysis pubis. Lower segment, symphysis pubis to the toes, and take the ratio. How does that ratio change with age? What is the ratio for a particular age? I will tell you just after 5 minutes. But just first pay attention. So calculate the upper segment to the lower segment ratio and ask what is the age of the child. He was 3 years and his upper segment to lower segment ratio, which is found at 3 years, is 1.3. I'm giving you an example. It is found to be 1.3. Normally also we expect it to be 1.3. So this child has a proportionate short stature. He does not have any disproportion in his body. He has a proportionate short stature. His upper segment to lower segment ratio is matching for that age. But if that upper segment to lower segment ratio is not matching for that age, this is a child who has a disproportionate short stature. It is not matching for that age. So he is a child who has a disproportionate short stature. Either his upper segment to lower segment ratio is more, or the upper segment to the lower segment ratio is less. If the upper segment to the lower segment ratio is more, then this will be called as infantile disproportion. And if the upper segment to the lower segment ratio is less, then it will be called as advanced disproportion. Infantile disproportion examples are achondroplasia, and congenital hypothyroidism. While advanced disproportion, the best example is spondyloepiphyseal dysplasia. So infantile disproportion, what are the two examples? Achondroplasia, it's a type of a skeletal dysplasia. Just remember, it's a bone disorder. It's a type of skeletal dysplasia. So achondroplasia. What is the second example of infantile congenital hypothyroidism, especially the congenital hypothyroidism which is untreated? On the other hand, example of advanced disproportion is spondyloepiphyseal dysplasia. It's again a type of a skeletal dysplasia. Spondyloepiphyseal dysplasia. So these are the two examples of disproportionate short statures. So they are examples of disproportionate short statures. On the other hand, what are the examples of proportionate short statures? So these are the two examples. Just write down the examples of disproportionate short statures. Upper segment to lower segment ratio, which is more for age, achondroplasia, congenital hypothyroidism. This is known as infantile disproportion. And upper segment to lower segment ratio less for age, this is advanced disproportion. Example, spondyloepiphyseal dysplasia.